So, acute pyelonephritis will present with features of infection such as lower UTI symptoms, dysuria, frequency, urgency, lower abdomen pain, and fever. Along with lower UTI symptoms, rigors and loin or back pain will also be present. To confirm our diagnosis, the initial investigation that we will do is a urine analysis, which will show blood, protein, nitrite, and leukocyte esterase. Nitrite and leukocyte esterase, their presence on a urine dipstick test indicates an infection. So if urine analysis shows nitrite and leukocyte esterase, and then to confirm the causative organism, we will send urine culture and sensitivity before starting or commencing empirical antibiotic treatment. So in acute pyelonephritis, the most common cause of acute pyelonephritis and UTI is E. coli. So what is the treatment of acute pyelonephritis? What are the suitable antibiotics? In non-pregnant women, the antibiotics, and in men. Non-pregnant women and men, ciprofloxacin 500 milligram BD should be given. And in patient with indwelling catheters who develop UTI, the drug of choice is co-amoxiclav 625 mg TDS or cefalexin 500 milligram BD to TDS. If moderate severity, then BD, and severe severity, then TDS. If the person is allergic to penicillin, then cefalexin can be used in patients with indwelling catheters who develop pyelonephritis. So what are the drugs that can be used in pregnancy for the management of pyelonephritis or UTI? Can any one of you tell me? We discussed them in yesterday's lecture.
Sorry, in pregnancy?
Yes.
It's trimethoprim and nitrofurantoin. Nitrofurantoin is contraindicated in the last trimester, and trimethoprim is contraindicated in the first trimester. So
yes, that's right. So nitrofurantoin and trimethoprim, remember that both of them are for lower UTIs. So if a pregnant female has developed pyelonephritis, so for lower UTIs, the drug is nitrofurantoin or trimethoprim. But in the females who are pregnant and they develop pyelonephritis, then the drug is cefalexin. And if they are admitted to the hospital or they require a hospital admission, then we will give IV cefuroxime. Cefalexin is a first generation cephalosporin, and cefuroxime is a third generation cephalosporin. Both are safe in pregnancy. So this was all about pyelonephritis and its management. Now our next topic is nephrotic syndrome. The definition of nephrotic syndrome is simple. Someone with proteinuria of 3 gram per 24 hour, hypoalbuminemia, serum albumin of less than 30 gram per liter, and edema, generalized body swelling. So if someone presents with these three features, that is proteinuria of more than 3 gram per 24 hour, hypoalbuminemia, serum albumin of less than 30 gram, and edema. Then we'll label this patient as having nephrotic syndrome. Hyperlipidemia can also occur in nephrotic syndrome because of increased hepatic lipogenesis, because the body try to compensate the decreasing oncotic pressure that is secondary to hypoalbuminemia by increasing the formation of lipids. So hyperlipidemia can also occur, and due to loss of albumin, there is hypoalbuminemia, which can lead to decreased oncotic pressure, and the person will develop edema. So due to loss of albumin, two things occur. One is edema, and the other is hyperlipidemia. Now, other proteins such as clotting proteins, for example, antithrombin 3 are also lost in the urine. So the person blood become hypercoagulable and he has a tendency to develop thromboembolism. And antibodies or immunoglobulins, they are also proteins. So they are also lost in the urine. So the person has a predisposition to infection. So due to albumin loss, hyperlipidemia occur. Due to clotting factor loss, anti-clotting factors such as antithrombin loss, tendency of developing thromboembolism can occur, and due to loss of antibodies, the person can develop sepsis. So remember this complication of nephrotic syndrome. Definition is proteinuria of more than 3 gram per 24 hour, hypoalbuminemia, albumin level of less than 30 gram per liter, and edema. And these three things will make the diagnosis of nephrotic syndrome. And the complication of nephrotic syndrome, three complications of nephrotic syndrome: hyperlipidemia due to low oncotic pressure, hypercoagulable state due to loss of antithrombin 3, and sepsis due to loss of antibodies. So the initial investigation in case of to confirm the diagnosis of nephrotic syndrome will be urinary protein creatinine ratio or 24-hour urinary protein levels. The blood test, initial blood test will include albumin level. So if a person will present to us with edema, these are the two tests that need to be done. And as I told you before, that any disease that is affecting the glomerulus, the definitive diagnosis will always be made on renal biopsy. Renal biopsy will show us the cause of nephrotic syndrome. The cause of nephrotic syndrome in children is, the most common cause in children is minimal change disease, and in adults, the most common cause is membranous glomerulonephropathy. And the second most common cause in adults is focal segmental glomeruloseclerosis. So if a child presents to you with the features of nephrotic syndrome, then you will think of minimal change disease. And if they ask you about the cause of a nephrotic syndrome, the most likely cause of nephrotic syndrome in children, then your answer will be minimal change disease. So whenever there is high protein in the urine will be described in the clinical scenario as foamy or frothy urine. So someone who presents to you with foamy or frothy urine and increased weight due to edema, The first thing that you will do is to do a urinary protein creatine ratio or a 24-hour urinary protein levels. And if they ask you about the definitive diagnostic test, then your answer will be renal biopsy. Complication, we have already discussed the complication: thromboembolism, sepsis, and AKI because the person developed edema. And when we diurese the patient, there will be loss of fluid and electrolytes. This can lead to pre-renal AKI. What are the common causes of nephrotic syndrome? In children, the most common cause is minimal change disease or minimal change nephropathy. In adults, the most common cause is membranous glomerulonephritis. And second most common in adult is focal segmental glomerulonephritis. Other causes of nephrotic syndrome: diabetic nephropathy can cause nephrotic syndrome as well. Multiple myeloma and amyloidosis can also cause nephrotic syndrome. That is a loss of more than 3 gram of protein in the urine in a 24 hours. So the most common cause of nephrotic syndrome in children uh, is the first disease that we are going to discuss. So if a child present to you with a feature of nephrotic syndrome, that is proteinuria, edema, and hypoalbuminemia, you will suspect minimal change disease, and it will be confirmed on renal biopsy. Renal biopsy will show fusion of podocytes on electron microscopy. We do not really do renal biopsy in children because it is an invasive procedure. So we just treat with steroids because the most common cause of nephrotic syndrome in children is minimal change disease, and it is an autoimmune disease, and it responds well to steroids. So we usually not confirm our diagnosis on renal biopsy. We just treat with steroids. But nonetheless, remember this finding of minimal change disease, that a renal biopsy will show fusion of the podocytes. Now, if someone present to you with isolated proteinuria or orthostatic, the other name for isolated proteinuria, what will you do? You will, so if someone has only proteinuria on urine analysis and there are no other clinical findings or no other abnormality, the first step is that you will repeat the test. And if after repeating the test there is still proteinuria, then you will advise 24-hour urine collection, and you will quantify the protein loss either on a 24 urine sample or a urine protein creatine ratio. And if the proteinuria is recurrent, then we'll confirm the diagnosis by doing a biopsy. So first step in isolated proteinuria is repeat the test, urine analysis or urine dipstick. If it again become positive, then you will do 24-hour urinary protein test or a urine protein creatine ratio on a spot urine test, on a spot urine sample. And if the proteinuria is recurrent, then you will do a renal biopsy to confirm the cause of this proteinuria. Now, the types of glomerulonephritis that present with features of nephrotic syndrome, we have already discussed the causes, the types of glomerulonephritis that present with features of nephrotic syndrome. What are the features of nephrotic syndrome? Proteinuria and edema. And some types of glomerulonephritis, they present with features of nephritic syndrome. So the main feature of nephritic syndrome is hematuria and hypertension. So we are going to discuss in detail which type of glomerulonephritis present with features of nephritic syndrome and which type present with feature of nephrotic syndrome. We have already discussed almost three causes, three types of glomerulonephritis that present with features of nephrotic syndrome. That is minimal change disease, which is the most common in the children, and that has a good response to steroid. An electron microscope will show fusion of the podocyte. The second type that present with feature of nephrotic syndrome is membranous glomerulonephritis. Membranous glomerulonephritis will present with feature of nephrotic syndrome, and it can progress to chronic kidney disease. Membranous glomerulonephritis, remember, 1/3 cases of membranous 1/3 cases of membranous glomerulonephritis, they resolve spontaneously. 1/3 responds to cytotoxic drug, and 1/3 develops into CKD, chronic kidney disease. So we can see that hypertension, diabetes, and membranous glomerulonephritis, they all can cause CKD. Another type of glomerulonephritis that can present with feature of nephrotic syndrome is the second most common cause of nephrotic syndrome and CKD as well is focal segmental glomeruloseclerosis, which is either autoimmune or it is secondary to HIV or heroin use. It will feature with nephrotic feature of nephrotic syndrome, and it can also develop into CKD. So these three types of glomerulonephritis that are minimal change disease, membranous glomerulonephritis, and focal segmental glomeruloseclerosis. These three can present with feature of nephrotic syndrome. Also, these three can develop into CKD. So chronic kidney disease can be caused by hypertension, diabetes, and these three types of glomerulonephritis, which present with feature of nephrotic syndrome. Now, what are the types of glomerulonephritis that present with the feature of nephritic syndrome, such as hematuria and hypertension? The first of them is Goodpasture syndrome or rapidly progressive glomerulonephritis, which is also known as crescenteric glomerulonephritis because the biopsy will show a crescenteric glomerulonephritis, and we have discussed it already that it presents with the features of acute kidney disease or acute kidney injury. So this is the first type that present with the feature of nephritic syndrome. The other type that can present with the features of nephritic syndrome is IgA nephropathy, which is also known as Berger's disease, and the third name for IgA nephropathy or Berger disease is mesengoproliferative glomerulonephritis. So Goodpasture syndrome or rapidly progressive glomerulonephritis can present with feature of nephritic syndrome. The second type of glomerulonephritis that present with feature of nephritic syndrome is IgA nephropathy, which is also known as Berger's disease, and mesengoproliferative glomerulonephritis. All of them are the same, are the name for the same disease, that is IgA nephropathy. So someone with a history of respiratory tract infection, upper respiratory tract infection, and he or she develop hematuria 1 to 2 days after having upper respiratory tract infection, then the diagnosis that we will suspect will be IgA nephropathy, or Berger disease, or mesenteroproliferative glomerulonephritis. So these are the two types of glomerulonephritis that present with features of nephritic syndrome. There's a third one, that is post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis can present with mixed features, feature of nephritic syndrome as well as feature of nephrotic syndrome. So we'll keep it post-streptococcal glomerulonephritis on both sides. Remember that post-streptococcal glomerulonephritis can also develop after an upper respiratory tract infection. But post-streptococcal glomerulonephritis develop usually 1 to 2 weeks after upper respiratory tract infection, while IgA nephropathy develop 1 to 2 days after upper respiratory tract infection, and post-streptococcal glomerulonephritis develop 1 to 2 weeks after upper respiratory tract infection. So this was all about the types of uh, glomerulonephritis and their presenting features. So we'll end our lecture here today. The remaining topics we'll do tomorrow. Along with we'll start urology as well. So until then, it's a goodbye.